Thank you. Good afternoon. It's my pleasure to be here today. This is my 15th UCI Healthcare Forecast Conference. Been here in many different roles. My job today is to talk to you about mental health in California and then to talk about one community's approach to some of the issues and concerns. Kristof mentioned in the slides that you showed earlier that as it relates to healthcare, mental health is our number one priority, at least based upon that survey that was done. I think Norm Ornstein said it very well when he relayed the problem and the catastrophe that he experienced with his son, Matthew Ornstein. And by the way, I would refer you again to the Matthew Ornstein Memorial Foundation, mornstein.org, that he had mentioned. What a sad and unfortunate situation. And speaking to Norm about that, one of the biggest issues that his son had was access to the right care. And that is what I'm going to speak to you about. By the way, just before we get started, when I use the term behavioral health or mental health, I'm talking about the same thing. If I use the term mental illness or substance use abuse and addiction, that's a very specific item that we'll be talking about. Mental health and behavioral health, at least for our discussion today, can be and will be interchangeable. Behavioral health related diagnoses are highly prevalent. You all know this, but important to note that 7.5 million people in California are affected by mental or behavioral health problems. If Orange County is 10% of the state, that's 750,000 people that here in this community are affected by mental health disorders. And you can see the statistics as they relate to and compare to some of the other conditions that we are commonly treating and addressing, oftentimes having very, very specific systems and ways by which we're managing cancer or chronic obstructive lung disease or attending to Alzheimer's disease and neurologic disorders. Here's a condition that's increasing by 8% over the past 10 years. We must say, and I think we can say, that we can do better and should do better. And we're going to talk specifically about that. By the way, as it relates to California, behavioral health affects every part of the state. So here's a list of all the counties in California. There are 58 counties in California. Here's a list. And what you're seeing here is the number of emergency department visits per day due to behavioral health or mental health disorders, per day. There are thousands of individuals who are seeking care every day for mental and behavioral health issues. By the way, I hope that you understand the emergency room is not the place where people with behavioral and mental health disorders should be seeking care and should be receiving care. They are not designed for that purpose. And most emergency rooms do not have individuals who are trained and specifically capable of providing care in that service. But yet that's where they are receiving the care. But important thing here is that this is how often people are seeking care. In Orange County, bottom left, 470 ER visits per day. In Los Angeles, 1,465 visits per day for a medical condition, mental or behavioral health, those brain disease disorders, seeking care there, wrong place, wrong time. And we're going to talk a little bit about that in just a bit. The other thing to note is that the vulnerable in our communities are the persons who are most affected by these conditions. And if you look at the proportion of individuals with serious mental illness, homeless are affected 25%, while those who are not homeless, much, much less at 6%. And look at poverty. Those who are poor have serious mental illness more than double as often as those who are not poor. Okay. So this is a condition that is not only prevalent, but it is preferentially affecting the vulnerable in our communities. So what about care and what about care providers? Let me give you some sobering statistics. Currently today, California's supply of psychiatrists is meeting 80% of the need. So I mentioned 7.5 million people needing care. 80% of that need is being met today. And you can see the statistics there. 7,238 is the expected number of psychiatrists that would be required to treat everyone who needed that care if they needed a psychiatrist, and not everyone does. I will acknowledge that. And these are 2016 data. We are short 1,500 as of 2016. We are short more today than we were in 2016. The most sobering of these data is 2028, where the supply of psychiatrists is projected to decrease by 34%, from 5,800 today to 3,800 in 2028. We don't have enough time to talk about all the reasons why that is the case, but suffice it to say, there is a waning interest in the field of psychiatry. There are many reasons for that. This will be felt in our communities going forward. And then if we look at non-physician mental health providers, we see not quite as stark, but similar data, similar findings here, which is a shrinking of the number of providers. All of this at a time, of course, when California's population, although it has slowed a bit, is still increasing in numbers. And so this just doesn't work. We will not have enough of the traditional providers of care that we need. We don't have enough today. We will not have enough in the future. If you ask individuals regarding mental illness, if we ask individuals, do you believe that people with mental illness can obtain services they need? In this survey, 54% of people who did not seek care, they weren't seeking care, they just were asked the question, do you believe that people can obtain the care that they need? 54% responded, Californians responded, no. And then if you ask individuals who sought care at some time and were seeking care, 66% of them, now that's their lived experience, 66% of them said they have access issues. This system's not working. So what are the effects of work shortages and access issues? Obviously, a delay or avoidance of care is never a good thing. We have problems in our emergency departments. Many, many hospital people here in this room, and we see all the time that people are coming and seeking care in emergency departments, mostly because they don't have another choice, or they don't know where to go, and they don't know what to do. ER holds are something that are very common, where individuals are in the emergency room, they are seeking care, they are unable to leave because they might be dangerous to themselves or others. They're on a hold dictated by regulation, but there are no psychiatric hospitals, and I'll show you some data on that, or outpatient centers available, so they stay in the emergency rooms. The overall assumption, and it is an assumption, but I think it's intuitive to all of us, wrong care, wrong place, wrong time, wrong provider. Overall, that cost of care is higher than it should be. There is waste happening there, and that's an expensive deal. And that's where we are today. Speaking of payment, Medi-Cal is the most frequent payer for behavioral health services. I think most of you would know that and recognize that. But if we look at the state of California, this is data from 2018. Total visits in the emergency department for mental health services, 650,000 across the entire state in that year. 46% were paid for by Medi-Cal. 25% by Elizabeth's cohort of private insurers and commercial payment. And then you can see Medicare and private pay as well. And then if you look at discharges, again, the great majority, 42%, are paid for by Medi-Cal. Okay, so we have a Medi-Cal system that for the most part is the payer for mental health and mental health services along with commercial payment. There's a problem, however. Less than half of California psychiatrists treat patients with Medi-Cal. So I said we don't have enough psychiatrists, but not only don't we have enough, but the majority of them do not even take care of patients who are covered by Medi-Cal, which is the major payer for care. And you can see the reasons why physicians don't take Medi-Cal. You can relate to this in many different ways. And then most importantly, just think about access going forward. 2/3 of psychiatrists in California are not accepting new Medi-Cal patients. It's a serious problem and a significant issue as we think about going forward. I mentioned hospital facilities, psychiatric facilities. Let me get my data out here to make sure that I get it exactly right. What you see in the first graph are the total number of psychiatric facilities from 1995 to 2017. Going from 181 total psychiatric facilities in California, and now 139. In the past 25 years, 42 psychiatric facilities have closed or been closed. And if we look at the total number of beds, there's been a 30% decrease in the number of psychiatric beds from 9,300 in 1995 to 6,700 today. This is all at a time when the California population has increased 25% over that time, from 32 million to 40 million, almost 40 million today. So why has this happened? Again, we don't have a whole lot of time to go into the detail of this. Suffice it to say that there has been waning interest in operating psychiatric facilities. Maybe some of it is financial. Maybe is it because hospitals and health systems and others were thinking more about focusing on other things that might be more interesting to them, or maybe even financially more valuable to them. And maybe, just maybe, they weren't really thinking about the population or the community health as it relates to operating and running psychiatric beds. It's also difficult to do this. It's difficult to do it well, and that's a significant problem as well. Some additional data. There is a clinical psychiatric group that says that the number of beds per 100,000 people that is ideal for providing for the care, now that's in the usual and the typical care that is being provided, and I'm going to talk a little bit about an alternative, is 50 beds per 100,000. Today in California, we are at 17.16 beds per 100,000, where the ideal is 50 per 100,000. By the way, there is no state that has 50 per 100,000. The highest in California is San Francisco, has 34 beds per 100,000. And if you may have noticed in the ER data, they had the lowest ER use in the state of California per capita in the area of San Francisco. By the way, Orange County has 15.8 beds per 100,000, okay? So just some comments in summary then for this section, which is mental health and behavioral health disorders are highly prevalent, and they are especially affecting vulnerable populations. We do not have enough providers of care in the traditional method and means to care for this highly prevalent condition. And I will add my own editorial comment, we never will. We never will. We need alternative solutions. We need other ways to provide mental and behavioral health services, because if we try to do it by building more hospital beds, if we try to do it by hiring and recruiting more psychiatrists, more mental health workers, we will fail. That will not work here. We are failing today in many ways, and we will not succeed in the future. So we need an alternative approach, and let me tell you about one community's alternative approach. That community is, for many of you, your community. Orange County has, as one of the few communities in this country that has chosen to find a new way to care for people affected by mental and behavioral health illnesses. The creation of Be Well Orange County is a community-wide public-private partnership, a coalition committed to vastly improving the mental health for all residents. So if the vision is to vastly improve and to lead the nation in optimal mental health and wellness for all residents, the question is, well then, what are you going to do? How are you going to do that? Let me tell you how. The one thing we know for sure is that we cannot do it by trying to improve upon the current system. That just won't work. And so we need to undergo system transformation. And the transformation is one in which is taking what we have today, which is highly fragmented services, this little graphic on the left, where we can see people with severe disease, we see people with moderate disease, we see commercial insurance, we see government programs of Medi-Cal, et cetera, and then a whole lot of stakeholders, which include the criminal justice system, which include the faith community, which includes the school systems, which includes hospitals, which includes the County of Orange, which has the primary responsibility for caring for individuals who are covered by Medi-Cal, just like the other 58 counties in California. And understanding that we have a set of fragmented services, a group of individuals and organizations have been working now for almost 3 years, putting a blueprint together for transforming how care can and should be provided, and building a system of care, an integrated network of care that we believe will have a very positive effect on by transforming how care is delivered in this community. This is a list, and this is all very small. You can't probably read all of these, but I think you can scan those and see most of these. This is the short list of all of the organizations that are part of Be Well Orange County. Many of you in this room are part of Be Well Orange County and are participating in this public-private partnership in the process of transforming care. And most importantly, you see many of the cities in Orange County, you see the County of Orange itself, you see all of the hospitals and health systems in the community, and then many, many other organizations of importance like the Orange County Sheriff Department and the Orange County Department of Education and many others as well. So this is the coalition. These are the organizations and the people that are working to transform how mental health services will be provided in this community. We're focusing on three things in 2020 that I wanted to highlight for you. We're focusing on a lot of things, by the way. We're focusing on stigma reduction. We're focusing on early intervention and prevention. We're focusing on filling the gaps for areas that exist. And by the way, children's care will be a big part of this as well. And you saw that CHOC is an important, Children's Hospital of Orange County, important participant in this process, as many others as well. But these are the three big areas that we're focusing on for 2020. The first is to create a navigation and crisis response system. One of the reasons why access is a problem is because nobody knows where to go when they have the problem. What do I do? If I have a broken bone or if my wife's in labor, we all know what to do. But when my son or daughter, who's 19 years old and I'm no longer responsible for them, is having some paranoid ideation, what do I do? How do I manage there? She's not able or he's not able to care for themselves. How do we approach it? We need a navigation system. We need a single point of access. And right now we have at least 18 different points of access that are formal in mental health and behavioral health, and we have many, many, many more that are informal. Many that are informal. We need a single response, and we are in the process of designing, and then soon we'll be creating a navigation and crisis response system. The second is, I mentioned that ERs are not the place for people to go to receive care unless they have a medical problem. Most of these individuals do not. And so if we need to have places where they can and seek care, both for urgent need, whether it be a crisis or whether it be detoxification, or for ongoing care. And we need places, and we're calling them wellness campuses, where this can occur. And then we need an infrastructure for an integrated network. So there are many, many really highly qualified and capable providers of care in this community. They're just not connected. They're not connected to each other. And so we need to have an infrastructure for that integrated network, and technology will be a big and important part of that. Let me talk about navigation very quickly. By the way, much of what we're talking about in navigation, we don't have to reinvent the wheel on this, because in Maricopa County, Arizona, which is Scottsdale, Phoenix, they are doing an excellent job at navigation. And these are some of their data from a community there, 4.2 million people in Maricopa County. These are some of their data that they've discovered. And we would like to be able to do things such as this. They receive about 25,000 primary calls to their single phone line or app per month, and of those 25,000 calls, they are able to stabilize and then triage 80% of those calls, 80%. 15% of those individuals need face-to-face stabilization, and they have over 30 mobile response teams that go to the site of the care that's needed, and that's done using a Uber-like app where they distribute or they send out those care teams to go determine and do an assessment on site. On site might be home. On site might be in jail. On site might be on the street. It's wherever that care is necessary. That face-to-face stabilizes another 15%. Only 5% have to actually go to a facility and seek care. Okay, so they are now triaging in a very effective way, something that we don't do, which is why 470 people are showing up in Orange County emergency departments every day to seek care because they don't know where to go, and their families don't know where to go. We are putting this system in place, and we are in the process of designing and developing this today. We think that this can be and should be in place here in Orange County by the summer of this year. And then I mentioned facilities. So we know that emergency rooms are not the place. And so we've decided that we need to have the right places to provide care. The first of 2 or 3 wellness campuses, Be Well campuses, is now coming out of the ground at 265 Anita, which is in the city of Orange. It's right next to the river near the 22 and 57, right by Anaheim Angel Stadium. This facility, 60,000 feet, which is providing 7 different services, is coming out of the ground today and will be done by December 2020. This facility will be owned, the land is owned by the County of Orange. The facility will be owned by a private not-for-profit that we've created called MindOC. That's the organization that I'm part of today. It will be run by the county, who will outsource all those services to 7 different providers: crisis stabilization, detoxification, short-term up to 14-day transitional housing, and then longer-term supportive housing up to 90 days in this 60,000 square foot facility. This is a $35 million facility. It's already been paid for, and the organizations that paid for it are listed on the bottom of that slide, and you can see who they are. The one on the far left is the County of Orange, and you can recognize the others, okay? These are the organizations that are now committed to this process. This will be open in the end of this year. We'll have a second facility in South Orange County. We hope to be identifying the location of that very soon. Kudos to the city of Orange for letting this be in their community. You can see how important that was. You know, NIMBYism is alive and well in many communities. And kudos to them for letting this go and endorsing this moving forward. Let's hope we are successful in South Orange County. An idealized outcome would be the following, at least the following. Every resident, all 3.2 million people, know what mental and behavioral health is, know what it is, and know what to do about it. Just like when people are having a stroke, you know what to do, you know what to do about it. Same thing for mental health services. And then every resident knows how to get care, hopefully through that unified front door. Navigation and an integrated network gives us the opportunity now to have the right care at the right time in the right way and the right provider. That should be less expensive. Think about the savings by eliminating the number of people. By the way, Norm Ornstein mentioned earlier that the largest facility providing mental health services in Los Angeles is the LA County Jail. Remember he said that at lunchtime? 1,200 people are in the Orange County Jail whose only crime is that they are mentally ill. And the reason the sheriff keeps them there is because if he lets them go, he knows they're going to come back. It's easier and less expensive just to keep them there rather than to let them go and have them come back. And so just think about the savings by not having mentally ill people being held at the county jail. It's very significant. We can turn those savings into more care going forward. And then the results are measured and reported. I look forward to any questions that anyone might have.